Now, this is the front window of the eye called the cornea. And then behind that, there is a space called the anterior chamber, which is a fluid filled chamber. Then you've got the iris, the colored part of the eye. And in the middle of the iris, you've got the pupil, which is essentially an opening to the lens, the natural lens behind the iris. And then behind that, there's a huge space called the vitreous cavity, or the gel cavity. And right at the back of the eye, you've got the retina, or the film of the eye. And almost in the middle of that, you've got what's called the optic nerve, which is the structure that gets damaged in glaucoma. But unlike many other eye conditions, glaucoma involves damage to the optic nerve due to problems at the front of the eye, and I'll explain that in a bit more detail. So this is a picture of the optic nerve, which is a orange yellowy structure at the back of the eye, which contains about 1.2 million fibers that are then transmitted to the brain, which then processes the information that you see. And coming out of the optic nerve, you've got multiple blood vessels, which both bring blood to the eye and take blood away from the eye. So, what is glaucoma? It's an acquired condition, i.e. you develop it with age, which is usually progressive, i.e. can get worse with time, and that results in damage to the optic nerve, and it can be associated with high or normal pressure. And normal pressure for the majority of the population is somewhere between 11 and 21 millimeters of mercury. And I'll be referring to the pressure in the eye as intraocular pressure, or IOP. And it results from impaired drainage of fluid produced in the eye. And so that fluid cannot escape out of the eye, resulting in raised pressure. And I'll illustrate that in a minute. So this is a video illustration of glaucoma. So under normal circumstances, fluid is produced in the eye and drains out of the eye through the drainage system. And that is almost akin to a tap and a sink system. So you have fluid produced by the tap. Oops, sorry, 1 second. Just going to go back. Yeah, so fluid is produced in the eye, drains out of the eye. And there is a natural homeostasis, so that there's a fine balance between fluid production and fluid drainage, so that keeps the pressure within normal limits. And the fluid is drained through what's called the trabecular meshwork, which is the internal drainage system of the eye. And this is where almost 80%, so the majority of fluid, drains out of the eye. And if you think of the system as like a tap and a sinkhole, so fluid is produced by the tap, drains through the waste system. However, in glaucoma, there is a blockage of that drainage system, so that fluid being produced cannot drain out, so the pressure builds up in a sealed system. Remember, the eye is a sealed system. When the pressure builds up, this pressure is transferred to the optic nerve, which then gets stretched and damaged, and that is what glaucoma is. So, in terms of types of glaucoma, this can be divided into primary glaucoma, and that can be subdivided into open angle glaucoma, i.e. that drainage angle that we spoke about, and closed angle glaucoma. And the commonest type of open angle glaucoma are normal pressure glaucoma, i.e. you develop glaucoma with the pressure being normal at the time of diagnosis, and then primary open angle glaucoma, where at the time of diagnosis the pressure is above 21 millimeters of mercury. You then have the closed angle glaucoma, which is where the drainage system that I mentioned before is closed, causing high pressure and damage to your nerve. So this is just to illustrate the difference between the two. So this is a cross section of the front part of the eye, the anterior chamber, which I showed you earlier. And normally fluid is produced by this organ called the ciliary body, and it drains through the pupil and out of the internal drainage system called the trabecular meshwork. Now, when this system is open, but the trabecular meshwork is not working, i.e. in open-angle glaucoma, this is your typical open-angle glaucoma picture. However, in closed-angle glaucoma, what happens is as you get older, the natural lens gets thicker and thicker, and it pushes the iris against this drainage system, stopping the flow of fluid and closing access of that fluid to the natural drainage system, i.e. the drainage angle is closed. And that, in turn, can result in high pressure, which can then result in damage to the nerve called glaucoma. So, the other type of glaucoma is the secondary type of glaucoma. And this can again be divided into open angle and closed angle. And causes of open angle secondary glaucoma are pigmentary glaucoma, whereby pigment in certain individuals, usually young, short-sighted individuals, pigment gets deposited in the trabecular meshwork, the internal drainage system, which stops it from draining fluid out of the eye. The other common type is pseudoexfoliation, which occurs in patients usually above the age of 50, and it's again inherited, and you get abnormal material deposited in the drainage system, which stops the drainage system draining fluid out of the eye. Other causes include trauma, so injury to the eye, which can occur at any point. So if you've had an injury to the eye, you can develop high pressure glaucoma at any point in your lifetime. So it's really important for patients who have had injury to the eye that they're monitored annually by their optician if they're not being monitored in the hospital. And then you've got conditions like inflammation related or uveitis causing a secondary high pressure in the eye and sometimes glaucoma. So how common is glaucoma? Well, nearly 58 million people worldwide have been estimated to have open angle glaucoma. And the worldwide prevalence is about 2.2%, and in Europe 2.5%. And the commonest type in UK is open angle glaucoma. And remember, that can either be normal pressure or high pressure disease. And you can see from this graph that the prevalence of cases is set to rise significantly by 2040. So, what are the risk factors for glaucoma? Remember that the optic nerve is the power cable of the eye, and it transmits information all the way from the back of the eye to your brain. And that information the brain processes, and you interpret that as what you see in the world. And the important part of the optic nerve is that the retina and optic nerve both use huge amounts of energy to send visual information to the brain. And therefore, the optic nerve function can be affected by poor nutrition, and so nutrients are required for energy generation, impaired blood supply to the optic nerve, as the blood supply delivers oxygen and nutrients, and stress on the optic nerve, for example, from high pressure. So, risk factors for glaucoma therefore include impaired blood flow. So, for example, if you have low blood pressure or your blood pressure fluctuates significantly, that you have blood vessel spasm, so certain conditions like migraine or Raynaud's, whereby your hands are prone to getting very cold. They often go pale and red and painful. Irregular blood flow, such as with an irregular heartbeat, and the condition that I'm most concerned about is atrial fibrillation, whereby the heart beats very irregularly, so you get impaired blood leaving the heart, and the blood pressure fluctuates significantly throughout the day. Then nutrition deficiencies such as nicotinamide or B3, and also B12, which also can affect optic nerve function. and then increase outflow resistance. So there's more resistance to fluid escaping the eye in certain conditions like obstructive sleep apnea or in certain occupations such as wind instrument players. So additional risk factors, which are typically described for open-angle glaucoma, are age, family history or genetics, ethnicity. So certain ethnic groups like Afro-Caribbeans are more prone to developing glaucoma, and also medical history, as I mentioned, migraines, Raynaud's, sleep apnea. Now, in terms of risk factors for angle closure disease, a typical risk factor is being long-sighted. So if you have a very strong plus prescription in your glasses, that is a risk factor. Again, family history is also a risk factor. Ethnicity is a risk factor. So angle closure disease is more common in the Chinese population or the Asian Far East population. And certain medications can increase your risk of developing angle closure. So, for example, the big group of medications are the antidepressant medications in predisposed eyes, also antihistamines. Then there are certain anti-epileptics that increase your risk as well. So what about age, ethnicity, and glaucoma? Well, if you look at this graph, you can see that the number of cases per 1,000 people significantly increases with each decade of life, such that by the time you're 80, your chance of developing glaucoma is 66 in 1,000. And by the time you're 90, that's 1 in 10 chance of developing glaucoma if you're Caucasian. If you're Afro-Caribbean, that risk actually doubles to 2 in 10 by the time you reach 90. So what about symptoms of glaucoma? So David Crabb and his group from City Hospital asked 50 patients with moderate to severe glaucoma, what symptoms does your glaucoma give you? And they showed them a series of images, and the patients were asked to choose which image most likely reflects their glaucoma. And very interestingly, 54% of patients reported blurred vision in parts of their vision. Some patients reported missing areas, a blurred tunnel. Some people were not even aware. Even a quarter of patients with moderate to advanced glaucoma were not aware that they had any impairment. And the important thing is, and which is often patients are misinformed about with glaucoma, is that no patients reported a black tunnel. So in summary, the commonest symptom of glaucoma for patients with moderate to advanced glaucoma is blurred vision, which is usually in certain areas of their vision or visual field. Now, they also went on to ask, how does your glaucoma affect your vision? And these are word clouds, and the bigger the word, the more common patients reported the symptoms. So the commonest symptoms reported were things were missing in their vision, they were blurry, the items disappeared when they were looking at them, it was unclear, unfocused. And then the other question they asked was, how does your field loss affect your life? And the commonest things reported were reading, nighttime, driving, computer, walking. These were common activities of daily living which were affected by patients having moderate to advanced glaucoma. So moving on to treatment of glaucoma, and I'll be quite brief on this. The aim of treatment is to preserve the current level of visual function to maintain your quality of life. The only available proven treatment is to lower the eye pressure, but treatment will not improve the vision or the damage caused by the glaucoma already. So the key point here is that all glaucoma treatments aim to lower the pressure or lower the fluctuation in pressure. And treatment options to lower the eye pressure include eye drops, laser or selective laser trabeculoplasty, and surgery. And there's two main groups of surgery, which are the minimally invasive glaucoma operations and conventional glaucoma surgery. So at that point, what I would do is probably stop and then take questions.
Perfect. That was really good. Thank you very much, Rajan. We've already got quite a few questions up here. So and actually some of them I'm just going to go through. So talking about it was about the eye pressure and blood pressure, and obviously you answered that one, but it's also, can you actually feel high pressure in your eyes? You know, sometimes they have a pain in their eyes. Is that the pressure rising?
I think that's a really good question, and the answer to that is, for the majority of patients, that pressure is not felt in the eye. High pressure is not felt in the eye. And glaucoma is largely an asymptomatic disease, and pressure is largely asymptomatic. The only time patients genuinely feel pressure is when the pressure comes on acutely or rapidly. And that typically occurs in patients who develop acute glaucoma. They get rapid onset of pressure, and that causes the pain, redness, reduced vision. But for most people, and I've seen many people with very high pressures in the eye over a long period of time, and they don't really feel the high pressure.
Thank you. That does make sense. This one, obviously, these kind of like appeared when you were talking about kind of the graph about the prevalence of glaucoma in the future. And I think I know the answer, but I think that it would be interesting to sort of hear. But why is it predicted to rise so significantly? And I think we've had 5 different people tick that, you know, those 2 questions. So I think there's definitely an interest about that.
Yeah, I mean, the fact is that we've got an aging population, and so people are living much longer than they used to. And so, you know, a glaucoma is largely a disease of aging, where the natural drainage system loses function with age. So the longer people live, the more prevalent the disease is in that population.
Yeah, thank you. And
Yeah.
then we've got some on eye pressure. So we've got here. So does high eye pressure always progress to glaucoma?
No, it doesn't actually. So you can have high pressure in the eye without developing glaucoma, but high pressure is a risk factor for glaucoma, and only a portion of people, somewhere between a 1/3 to a half, will develop glaucoma, but a large proportion may never develop it. And
That's quite
again,
reassuring.
and again, it comes back to additional risk factors. So if you've got high pressure and no other risk factors, i.e., you haven't got a family history, then you know your risk of developing glaucoma, depending on what age you get high pressure, is quite low.
Yeah, that makes sense. So I've got a couple of people that actually in the pre-questions that they sent through are all about kind of like normal tension glaucoma, and it's basically kind of like, what if any painkillers can be taken on a regular basis for chronic long term with normal tension glaucoma? Are there any kind of like contra indications for that?
But to my knowledge, there's no contraindications taking analgesia or painkillers for which will affect the disease.
That's good. And then again, I don't think it's probably to do with normal tension, but someone about started using eye drops every night, but they've heard that vitamin B3 can be helpful for people. I know you mentioned B3.
Yeah.
So, but is that correct? So obviously, I know you have talked about that.
Yeah, so there's multiple studies going on throughout the world on vitamin B3, which is believed to, and the reason for the studies running is that they found that in patients with glaucoma, they found low levels of B3 in the blood. And so B3 has an important role in the energy production in the optic nerve. And because they found low levels in the blood, they decided to run a trial. Now, the dose of vitamin B3 they're using is very high. So the normal dose, the trial dose is 3 grams. The normal recommended daily allowance is somewhere in the region of 250 milligrams. So it's like it's like 12 times the normal dose. And there has been 2 cases now of liver failure from very high doses of vitamin B3. So I would not recommend taking the high dose. If you want to take it, take the recommended daily allowance of vitamin B3.
Thank you.
Sorry, just to add to that, until the results of the trial are published, we don't know whether high dose actually makes a difference. So it's better to err on the side of caution, especially when, if you had developed liver failure and you're not being monitored, because people in the trial are being monitored.
So they're putting their health at risk for something that we're not even sure whether it's actually going to be affected. Yeah. So you mentioned risk factors, and you did talk about the blood pressure, but someone actually just to I suppose just to sort of clarify, is high blood pressure a risk factor for glaucoma?
I think high blood pressure in itself is not a risk factor. What is a risk factor is fluctuating blood pressure. So often, particularly in the normal tension glaucoma, normal pressure glaucoma group, or the normal tension glaucoma group, it's the variation in blood pressure. Because remember, you need a certain level of blood pressure to push blood up towards the brain and therefore the eye. And if your blood pressure is fluctuating, so it's high, low, in certain conditions, particularly like atrial fibrillation, and then other conditions like where your heart's not pumping as well, then that's going to impair the circulation to the eye. So in high blood pressure, there is a problem with the blood vessels, and so your pressure goes high in the body. High blood pressure is a risk factor for many other things, but not specifically for glaucoma.
No, but obviously, maybe if it's low, what about low blood pressure? Would that be?
Good question. Low blood pressure is a risk factor for a normal pressure glaucoma. And one of the things we often see and speak to our patients about is, that if they have got low blood pressure and they have got normal pressure glaucoma, it's worth seeing their GP, particularly if they're taking the blood pressure tablets at night, which can further drop the blood pressure throughout the night when the blood pressure naturally drops, if that makes sense.
Mm-hmm. Thank you. This is the one about vision change. So can vision change during the day? So, maybe it might be blurry. And then someone else has also asked, I sometimes have blurry moments. I do, I wonder about this too. So is vision going to be varied throughout the day?
That's a brilliant question that patients often ask me. They actually say my vision varies throughout the day. And the reason why is, remember, your optic nerve is transmitting what you see in the world to the brain. So depending on how much information it receives, normally, under normal circumstances, your eye can cope with it because it's constantly generating enough energy. But if your optic nerve is failing or losing function, then it cannot send that information to the brain as efficiently as it should. And so when you're going from certain lighting conditions to other lighting conditions, it will take your eyes much longer to adapt. And so your vision may be temporarily blurry while it adapts, may not fully be as it should be because your eye's just not processing that visual information normally. So patients will often say that in certain lighting conditions, vision's more blurry. Going from certain lighting to other type of lighting, particularly from dim to light, very bright light, they often they can't see for a while, or the vision's very blurry.
Thank you. The other one as well is, if you keep normal pressure, does it mean you'll never go blind?
From glaucoma?
Mm-hmm.
There is a low risk. I mean, everyone with glaucoma, depending on severity, has a risk of losing vision. There is a risk, but the risk is low.
Okay, thank you. Then someone said, what is tension glaucoma? I don't know whether that's maybe normal tension glaucoma, possibly. So maybe that might help.
So tension refers to the pressure in the eye. So normal tension glaucoma is normal pressure in the eye at the time of diagnosis.
Thank you. And then we've got here, I suppose, there's a couple of ones that are kind of together. So your slides mentioned nutrition deficiency and how can this be improved? And actually, as well as another question which kind of goes with it, it says, is vegetarianism detrimental to the health of the optic nerves? So I'm guessing they're both kind of to do with nutrition and diet and stuff like that. So how can that affect things?
Yeah. So I think vegetarian per se is not detrimental to the eye. it's the nutritional deficiency as a result. And you know, I'm vegetarian, and so I have to be mindful that I'm eating nutrients that often, you know, I can't get from animal products because I don't eat them. So I make sure that I get my B12 tested regularly, and I actually take B12 to make sure it doesn't drop low. So we've just got to adjust our lifestyle based on our diet. And although B3 is not tested regularly, so GPs won't test you for B3 routinely, you can make sure that you take nutritional supplements, particularly a vegetarian or vegan, and make sure you eat quite a broad all-round diet.
Thank you. This one is again, you know, you mentioned about kind of like if you play the woodwind instrument. So there's a couple that are kind of very much kind of like based on activities. So obviously one is obviously putting a lot of pressure on your eyes when you're playing a wind instrument.
Yeah.
The other one is there any activities that you should avoid, like yoga or using a sauna. So I'm going to put them together because they're all kind of like things that could affect your glaucoma.
The thing is, there's a balance between the disease itself and your quality of life. So I think even if you have glaucoma, I would say if it's very severe, then you want to do everything you can to mitigate some of these risk factors. So the woodwind or yoga, etc., particularly head down posture. But if you've got high pressure in the eye or early glaucoma, and yoga gives you a good quality of life, so it keeps you fit, keeps your mental state in check, then, you know, I would say that's more of a benefit than a risk to you, because also, you know, studies have shown that yoga, stroke meditation, and reduced stress also can lower your intraocular pressure. So there has to be a balance.
Thank you. So I was just thinking about so someone actually this is more of a medication, but I'm guessing it's not specific to them. They have a dosolomides timolol preservative-free single dose, but the pharmacy gave them 5 ml bottles, not a single dose. Is that okay?
That's
so obviously, yeah.
As long as it's preservative-free, dosolomides timolol is available multi-dose as well as unit dose.
So, and then someone said, can the optic nerve be repaired? I know that you mentioned that, but I know that there's probably things afoot, isn't it? That's what they're kind of looking at. So it might be worth.
Interesting. I mean, there's lots of work going on into nerve regeneration, but the problem is that the regeneration has to occur all the way from the back of the eye to the brain. And that is a long distance for nerves to grow. It's huge. And in fact, at a recent meeting, one of our esteemed colleagues, Sir Peng Kaur, said that for the optic nerve to grow, it's like traveling from central London to Heathrow Airport. That's the distance it has to grow back. So, I mean, to achieve that, I mean, we're a long way off from that. So the answer is we can't regenerate the optic nerve, not now. But I mean, lots of people are working on it.
That's reassuring, but obviously not quite yet. So, and again, this normal pressure, normal tension glaucoma, I've just been diagnosed with normal pressure glaucoma. They found on an eye test, left eye only. They have no family history, but they had chemotherapy, and so they were wondering whether that might have caused the glaucoma, and if so, would they be concerned about the progression?
Yeah, I mean, it depends. So chemotherapy per se doesn't cause glaucoma, but sometimes with chemotherapy, depending on the type, steroids are often given. Now, if you're slightly predisposed to raised pressure and you're given a course of steroids over months and months, that could have potentially put the pressure up, damaged the optic nerve, and when the steroids were removed, the pressure came down, but then you're left with some damage. Some medications, chemotherapy drugs, directly damage the optic nerve. So, I mean, it's either something related to that, if it is the chemo itself, but it might not be. It could be, you know, just the age-related factor. So it's very hard to tell whether it's chemotherapy or not. It's hard to distinguish.
No, thank you for that. So actually, someone here has asked, and I'm going to lump this one together. How is glaucoma diagnosed? And we've got quite a lot of people saying about, if you've got normal pressures, then how is that glaucoma? So obviously that's going to be quite a hard one to diagnose. So how is glaucoma detected, diagnosed, and if you haven't got high pressures, how do they know even more, about glaucoma?
That's a great question. So remember, glaucoma is damage to the optic nerves, either because of normal or high pressure. So how do we detect damage to the optic nerves? And bearing in mind that it's an asymptomatic disease. So what opticians do, because opticians largely make the suspicion and then refer on to a specialist. So how do they do that? Well, you've got two optic nerves, and largely they should be very similar in appearance. So when one optic nerve slightly looks abnormal compared to the other, then what they do is then they go on to do various tests. And the tests of optic nerve function are a visual field. But remember, you can have glaucoma and have a normal visual field. So then they also look at the structure of that optic nerve and using an OCT scan. And what the OCT scan looks at is, very brief, is that it measures the thickness of the fibers feeding into that optic nerve and compare the patient's results to someone in the same age group without glaucoma. And when the scan of the optic nerve falls outside what's an acceptably normal limit, patients are often referred regardless of what the pressure is.
Yeah, yes, it's all very complicated. So this one is about eye washes. So if you use an eye wash while you're on the glaucoma drops, will it reduce the effectiveness of the medication? So if you're going to use, and I'm guessing we could probably open that out to be using dry eye drops as well. Yeah. How can people be sure that they're not going to interfere with their own medication?
Good question. So I always say leave a minimum of 5 minutes gap between any drops, because potentially one could wash the other one out if you're putting one after the other. So if you just have a rule that always leave 5 minutes gap between any drops that you use, whether it's dry eyes and glaucoma or glaucoma and glaucoma drops, then that will give time for the eye to absorb the medication you've instilled.
Thank you.
Yeah.
So it says, can a cataract be removed when one eye has glaucoma?
Definitely. I think the thing about cataracts and glaucoma, which is in itself a very interesting topic, is both of them can cause blurred vision. And it's sometimes hard to distinguish the two. But yes, it can be removed. But during the consent process, it's really important for patients to understand that sometimes if patients have very severe glaucoma, removing the cataract may not improve a lot of the blurred vision, because a lot of the blurred vision could be due to the glaucoma itself.
Yeah. Yeah, I can imagine it'd be quite, hoping for a cure and then realizing actually it didn't solve it fully. We've got a question, and I kind of know it's probably more about specifics, but I think maybe if we can look at the general one, it's someone's got early glaucoma in one eye and moderate in the other, and they're talking about following their treatment regime, and is it possible for their progression to be halted? And someone else said, if my progression is, how can I know what my progression is? No, I'm guessing it's about people want to know if they get detected at a certain point, are they likely to lose their sight? And I'm guessing that the answer is probably not going to be, it depends on themselves, isn't it? There's no magic writing.
No, exactly. So it depends on many things. So it depends on the age at which it was diagnosed, on the severity at the time of diagnosis. The type of glaucoma is relevant. So certain types of glaucoma, i.e. pseudo-exfoliation, which is a secondary open-angle glaucoma, has a greater risk of progression than your usual age-related glaucoma. Some people with normal tension glaucoma, they don't get worse. Even if you treat them or not treat them, they don't get worse. And it's hard to know which group that is. So 1/3 of patients in the normal tension treatment glaucoma group didn't deteriorate. So it's very individualized, and the only way to know is to watch over time. And that's where the OCT scan and the visual fields come into play.
Thank you. It's so we answer one question, then we get like the same kind of like, oh, and it kind of like, so someone, it's just a quick one. So talk about fitness activities, again, backwards and forwards, but weightlifting. So what about things like weightlifting?
Yeah.
What do you
when you lift heavy weights, you hold your breath. When you hold your breath, you get increased outflow resistance from the eye, albeit for a short period. But again, there's a balance between risk and benefit. So if you've got early glaucoma, high pressure, then it's not a problem, because that forms part of your exercise, your strength building, and it's important for your well-being. But if you've got very severe glaucoma in one eye and you've only got one good eye, then you probably want to avoid holding your breath for prolonged periods, i.e., weightlifting, those type of things.
No, yeah. So it's a trade-off, isn't it? You've got to sort of balance things out. So how can you explain how do eye drops actually work for lowering the pressure? I mean, why we're told they do, but why? How?
Yeah. So there's different classes of eye drops work differently. So the commonest type of eye drop we use for glaucoma is the prostaglandin analogs, such as latanoprost, bimatoprost, etc. And they work by increasing outflow from your eye. So it causes the blood vessels to open up within the eye, and so fluid can escape through there's two drainage systems essentially in the eye. You've got the trabecular meshwork, which drains about 80% of fluid out of the eye, but then you've got what's called a uveoscleral system, which is essentially another blood circulation system which clears fluid. So the prostaglandins work by the other system, and it enhances that system's outflow. But then you've got other eye drops, such as dorzolamide, timolol, that type of medication, which suppress production of fluid in the eye. So they're turning down the tap, if you like. So you've got either you're increasing drainage out of the eye, i.e. through the sinkhole, or you're turning down the tap. So that's essentially how the word drops work.
Thank you. So we've had one here, and it says, we talked about kind of lowering or the fluctuating blood pressure, and so there's questions as why is more not being done to look at the research into fluctuating blood pressure and how to manage it when it has such an effect on the eyes.
I think the problem is everyone's blood pressure fluctuates, and we all have a natural pattern in blood pressure change, and it very much depends on your level of stress, your sleep, and there's so much variation in that. And they have looked at impact of low blood pressure and glaucoma, but not so much in fluctuating blood pressure and glaucoma. And yes, potentially that could be looked at. And in fact, I mentioned atrial fibrillation, where the blood pressure does fluctuate, and they have looked at that actually, and they have found that patients with atrial fibrillation, where the blood pressure varies and fluctuates, are more at risk of glaucoma and glaucoma deterioration.
So I mean, they also mentioned what about a biofeedback mechanism? They wouldn't mind being woken up if their blood pressure got low, to sort of trying to sort of think. I don't know whether that would be how that would work.
The problem is that, first of all, if you have sleep disturbance, that's very bad for your general health. Secondly, is even if you were woken up by that biofeedback mechanism, what could you do about it? It's very hard to raise your blood pressure. I can't think of any treatment that will work to raise your blood pressure quickly, in the middle of the night. And that's the problem with having continuous monitoring, is that it will disturb your sleep, disturb your peace, which will make you more stressed, which can have an adverse effect on your blood pressure. So,
yeah, no.
I mean, for people that are worsening with normal pressure, and there's concerns about low blood pressure, you can have a 24-hour blood pressure monitoring done through your GP. And if your blood pressure is dipping very low, particularly at night, then that gives your GP evidence to alter the blood pressure medication. to avoid those very low blood pressure episodes.
Okay, so
so there is that option.
Yeah.
Correct.
Thank you. This one's quite good. They accidentally put 2 drops into the eye, and they were wondering whether there was any problems. And sometimes the first drop leaks out of the eye. So is there any problems about putting 2 drops of their medication in the eye at the same time?
Because the eye can only take 1 drop essentially, and if you put another one in by accident, i.e. 2 drops, the second one will probably run down this lower lid, but it's not going to harm you.
Thank you. And this one is dry eye common with glaucoma?
Yes, definitely. So dry eye is much more common in glaucoma patients than similar age group of patients without glaucoma.
Thank you. So someone's asked about the conventional surgeries and how successful they are, but I'm guessing that we will be talking about that, but we could probably just talk a little bit about them, and they want to know the risk and stuff, but of those.
I mean, and Nishani will be talking about that probably in the next month's meeting. But basically, so conventional surgery is the 2 main types of trabeculectomy, which is almost the gold standard operation, and it's been around for at least 40 years. And an aqueous shunt implant, which is a silicon implant which goes into the eye, front chamber of the eye, drains fluid out of the eye. And they've got a good track record, a good success record, but their risk is greater than, for example, MIG surgery. But they're not often used for the same cohort of patients and same disease progression. So I would say every patient is individual, and every condition that a patient has to be looked at in the context of their age, their type of disease, their stage of disease, etc. So, for what a conventional surgery may be the right procedure for one patient may not be for another patient.
Thank you. Yeah. So we've got back to drops again. So one person's having difficulty to measure. It's difficult to measure the drop size. Sometimes a larger or smaller drop goes into the eye. So they were talking about whether it's crucial to correct treatment, and then someone else, should they be put in a certain part of the eye, or should you move your eyes to spread it around? So it's about, I suppose, those drops, getting them, those tricky things, getting them in the eyes, and how is it, when's it okay to not to panic about, have I got it in the right place?
Yeah, I think the problem with eye glaucoma drops, especially generic ones, is that there's many manufacturers, and the volume that is dispensed varies tremendously. So some patients say that when they squeeze it, hardly anything comes out. Then they get another bottle the month afterwards, and too much comes out, and it runs down their cheek. What I would say is that if you note a brand that suits you, in other words, it's easy to squeeze, 1 drop easily comes out, take a picture of it on your phone and say to your pharmacist, this is the one I prefer, this suits me the best. And in terms of where to put it, I generally recommend you that as long as it goes between the inner eyelid and the eyeball, that drop will spread throughout your eye as it moves.
Thank you. This one, it's not really kind of like part of this thing, but I just want to make sure it's answered. It's kind of, this person's been using glucosamine and sulfate for years, and then our last webinar, they were concerned to hear it's bad for patients with glaucoma. So I just wanted to kind of and also if you have an MRI scan, they ask you if you have any stents. So it's about, I suppose, a little bit of clarification on that, if that can help, please.
In terms of glucosamine, I have to admit, I don't know the data on glucosamine, so I'm sorry I can't, but I can look it up and always come back to you. And
thank you.
In terms of stents and MRIs, most of the MRIs, most of the stents you can actually, they're safe to have an MRI, and when you have a stent, you're usually given a card which says that you've got a stent in your eye and it's MRI safe. So just be mindful, if you're planning to have a stent, make sure you ask your surgeon to provide you with a card which actually comes with the stent in the box, to say that this stent is MRI safe. But the problem is, once you say that you've got a stent, they won't do an MRI because they're not sure if it's safe or not. But if you've got an official card which states that this is an MRI safe stent, then it's not a problem. But most stents, iStent, Hydrus, they're all safe to have an MRI with.
Just make sure you get that card.
Exactly, yeah.
Yeah. Again, this normal tension glaucoma is not going anywhere this evening. So how do they know if it's normal tension glaucoma or secondary glaucoma?
Yeah. So first of all, with secondary glaucoma, you'd find other underlying factors. So that's where the examination comes in when you come to the hospital. We look for the other features of secondary glaucoma. If they're not present and the pressure is normal at the time of diagnosis, then it's most likely normal tension glaucoma. We also check for other features which may make us a bit weary that it's glaucoma or not. So, for example, vision rapidly with normal pressure, if your color vision is impaired, if it's very unilateral and very severe in one eye, then we may wish to think, is this glaucoma at all? Could it be another type of optic nerve damage, which is not glaucoma? And in those type of scenarios, we and I often do an MRI scan of the eyes and the brain, because remember, the optic nerve is an extension of the brain, and also refer to our brain eye colleagues or neuro-ophthalmologists for further investigation.
Thank you. This one I'm going to put together. So it's talking about kind of how do you know what stage of glaucoma you have? And the other one is kind of like, what do I do if all the treatments don't lower my pressure? So I'm guessing that's all part of that journey. So
the severity of glaucoma is based on the visual field test. And on the visual field test, when we look at a visual field test and interpret it, first of all, we look at, is this field reliable? If it's reliable, then we look at certain parameters on the field. And one of them is a global parameter called the mean deviation. And that's how different your field is compared to someone of the same age as you. And what we're looking for is a change in that mean deviation over time. And the mean deviation value will determine whether it's early glaucoma, moderate glaucoma, or severe glaucoma. And that's how we judge severity of disease, essentially. In terms of your other question, was it on NT normal pressure?
Sorry. It was to do with what happens if all the treatments don't seem to work, lower the pressures.
So remember, if the pressure doesn't come down to an acceptable level to stop your disease getting worse, and you're still getting worse despite using all the drops, then there's a few options depending on severity. You can have laser, SLT laser, to try and stimulate your natural draining system to drain more fluid out of the eye. Or if that's not an option or that doesn't work, then it will be surgery. And which operation will be determined by your consultant based on many factors, which they will go through with you.
Thank you. Actually, while we're talking about SLT, it says that, is it true that taking drops might make SLT unsuitable? And how long do you need to be on drops before it's no longer an option? Or is it just that SLT is only for higher eye pressures?
Yeah, so in terms of pressure effect in SLT, the higher the pressure before the laser, the greater the magnitude effect. But also SLT also has been shown to not only lower the pressure, but lower the fluctuation in pressure. And that was from the light study from Moorfields, which they found that they basically, just to summarize it, they compared SLT versus drops in newly diagnosed patients, and they found that both groups were being treated to a target pressure, but the SLT group was less likely to get worse. So the laser is lowering the pressure, but it's also probably lowering the fluctuation in pressure, which is just as much a risk factor for glaucoma deterioration as the absolute pressure, if that makes sense.
Yeah. Yeah. This is actually quite a positive one, actually. So they've had trabs in both eyes, no drops now after 25 years of a year of using them. Can your eyes feel different after having surgery?
After trabeculectomy, potentially, yes. I mean, on the positive side, you're saving yourself from committing to drops every day, which have side effects that can make your eyes sore and red and inflamed. But trabeculectomy, because you've got a drainage bleb, if you like, which is almost a channel on the surface of the eyeball, that raised area can cause a bit of irritation, redness, sometimes a bit of a foreign body sensation. So there is potential to cause some symptoms after trabeculectomy. But I guess the flip side is that you're not using drops every day and having side effects from drops.
So I think we've probably got time for another couple of questions. One that I was going to ask about, if it's Ramadan coming up soon, and obviously we've had patients, we've on the help desk sort of worried about it being kind of part of their, if they're fasting,
Yeah.
then what would your advice be for people like that?
So to my understanding, because the medication is for health treatment, you are allowed or permitted to use the treatment.
And actually, because it goes into the eye as well, it's not really, you're not swallowed like a pill either, is it?
Exactly.
So
exactly.
yeah, thank you. And someone says, what is cupping?
Yeah, good question. So your optic nerve is made up of two components. You've got the if you imagine a tire, yeah, if you picture a tire, you've got the tire, the tire itself, the black portion, but inside there's a hole in the middle, which is empty. So the optic nerve is the same. So that if we look at the tire analogy, the black area is all the axons, the fibers that come from the retina and go to the brain. The middle bit, which is not technically empty, but you can say it's empty, is where blood vessels traverse in and out of the eye. So, with glaucoma, when your nerve fibers start to lose function and effectively die, the wheel, the black portion, gets thinner and thinner and thinner, and so the cup size, the hole increases as those nerves thin out and die. And as that cup increases, that's called cupping.
Thank you. I think probably one last question, then I'm going to sort of launch the poll. And this person said, does a failed SLT impact the chances of success of trabeculectomy? And they've also asked, is a recording, and there is a recording afterwards, so you'll be able to catch up all the wonderful kind of like information that Rajen's given us earlier. So, but yeah, is a failed SLT impact any other chances of treatment?
No.
Perfect. So what I'm going to do is we've got another couple of minutes. I'm going to launch the poll again, and I'm going to just share my screen while I'm doing that. And there we go. So there we go. From current site. So thank you very much, Rajen. I really for spending time with us, for doing this. We always really appreciate having kind of experts helping us. I'm just trying to work out where the polls are in here. Let's see. There we go. Right, polls. Sorry, I'm so used to using other devices when they sort of like go onto live that Zoom sometimes isn't always I'm not very familiar with Zoom, so I apologize. Right, so I want to say thank you for joining us. If we haven't answered any of your questions, I really apologize. We've had so many questions. It's been amazing. So you can give the helpline a call 9:30 till 5 every weekday, or send them an email. They will be able to get back to you. As Rajen said, the next one is on the treatment ladder, which is Nishani, a lovely consultant from Southampton, is going to be doing that with me again on the treatment ladder. And then the 2nd of April, it's our very own Joe Hodgkinson is going to talk about research. So hopefully you'll enjoy both of those and sign up. And thank you very much for spending some of your evening with us at Glaucoma UK. So thank you very much, Rajen, for all your kind of like support.
Thank
and I'm
you.
now going to stop sharing. But yeah, so thank you very much. And I'm now going to end the webinar. So